in London. And the topic will be about grown-up congenital and if there is a real need for CMR. We enjoy you. Go ahead.
Thank you. Thank you very much, Sophie, for the kind invitation. I'm very happy to be with you this evening again. So I hope that you can see my presentation. So let's see, do we really need the cardiac MRI in growing up congenital heart disease? So this ACHD population is actually a growing population as due to medical, surgical, and technological evolutions over the past decades. More than 90% of individuals with congenital heart disease who are born now survive into adulthood, and the prevalence of congenital heart disease in the community has increased and now by far exceeds the number of children with congenital heart disease. Don't forget that this population, these patients may need to attend your hospital even if you are not a specialist center. So we need to know some basics. And definitely the CMR has a role. The question is if CMR has always a role or not. This is the classification of congenital heart disease complexity according to guidelines. A large table. Why imaging matters in good population? It is very important for the assessment of residual lesions, for conduit dysfunction, for the assessment of arrhythmias to see if there is any substrate causing the arrhythmias, for the further assessment of heart failure, and what we actually need is accurate, reproducible, and anatomy-specific imaging. And the CMR has some strengths compared to echocardiogram. It is the gold standard for the assessment of right ventricular and left ventricular volumes and function. It offers a high-resolution 3D anatomy. It assesses accurately the flow, the SUNS, QP to QS, and their regurgitant fractions. And of course, it offers a unique technique, the tissue characterization for the assessment of fibrosis, scar, or iron overload if needed. On the other side, we have the echocardiography, which is easy to be done, more easily accessible, cheaper, and however, it has some limitations like the poor acoustic windows, especially post-surgery. Limited, we can have a limited view of extracardiac structures. It underestimates the right ventricular size and function, and the quantification, especially in complex anatomy, the quantification of flow might be inaccurate. So in which scenarios we should consider cardiac MRI? It definitely has a role in the trialogy of Fallot for the assessment of the right ventricular size and the assessment of PR in order to determine the timing of pulmonary valve replacement. In Fontan circulation for the assessment of conduit patterns in systemic venous return. In transposition of great arteries for the assessment of valve leaks and right ventricular function. In coarctation for the assessment of arch anatomy and collateral flow. In aortic valve disease and aortopathies, including after Ross operation. In ASDs, as we can see the anomalous pulmonary veins, something that we can't see with echocardiogram, and of course in anomalies including pulmonary valve and tricuspid valve, such as in Epstein's. We will go through some examples of these clinical scenarios. So we will have the opportunity to see how CMR can has some advantages compared to echocardiogram. So it has a role in somebody who has known AC as ASD for the further assessment of the right ventricular size, the QP to QS, in order to see the rims, although the TOE is quite good at that, and the anomalous pulmonary vein drainage. If we have a suspected ASD, the CMR definitely has a role to elucidate if the cause of right ventricular dilatation is an ASD, or there are other causes of RV dilatation, including IVC, isolated anomalous pulmonary vein drainage, pulmonary hypertension, or left ventricular failure like DCM or ischemic cardiomyopathy. And the goals is to assess the right ventricular size, the shunt QP to QS, to check for pulmonary venous return. The most common anomaly is the abnormal drainage of right upper pulmonary vein, the number and the size of the ASD, and if there is tricuspid regurgitation. So here you can see the usual technique that we use. We take atrial sinus-stack images with 5 mm slice thickness and no gap, and we take these images. We will see more examples. We can also use the flow images, the phase contrast, to visualize the jet in plane or through plane. And this is a very good example of why CMR has a role in specific cases of ASD. In this paper, which included 44 patients, the end-phase ASD imaging gave inaccurate information on ASD flow, size, and morphology. And most importantly, it changed the management in 20%. Very characteristic is that this patient, where initially thought that he had two secondum ASDs, and the initial plan was to do a percutaneous close. However, the CMR saw that there were three ASDs in a thin premium, fenestrated premium, and then the plan changed from a percutaneous intervention to surgical close. Don't forget to check for pulmonary veins. Here you can see an anomalous drainage of right pulmonary vein to superior vena cava. It's something that we should always have in our mind. This is another example, a 60-year-old woman with large atrial septal defect seen on echocardiogram, and we proceeded with a cardiac MRI for further assessment. You can see in cine images the aneurysmatic ASD with the flow from left to right. You can see the dilated left ventricle, which, however, contracts very well. And then we took left atrial stack, and you can see very nicely the secondum VSD here with the flow, the shunt from left to right. And then with the phase contrast, we took the flow through aorta and pulmonary artery, and we assessed accurately our QP to QS. And indeed, we can measure the rims with CMR. Typically, traditionally, I would say some centers prefer the TOE, but definitely CMR can help us with that. So here you can see the magnitude sequences and the phase contrast sequences. So with ASD in phase, we can measure very well the position and the size of ASD, and then we can take sequences where we can measure the rim from the superior vena cava, the rim from the aorta, the distance, the rim from inferior vena cava, and the rim from the mitral valve, which is very important in order to decide if we can proceed within a percutaneous closure or not. And this paper showed that indeed the cardiac MRI agrees with TOE assessment of ASDs in the workup for percutaneous closure, and potentially cardiac MRI could be used instead of TOE for this purpose. And why we prefer CMR versus echo in the assessment of right ventricular volumes? Because it avoids the geometrical assumptions that we have to do in echocardiogram. It offers 3D visualization, and it has high spatial resolution and reproducibility. It is very important to assess accurately the right ventricular volumes and the shunt, because these two parameters lead us in our decision regarding closure or not closure and the type of closure that we will decide. Here you can see the types of ASD. Of course, the most common one is the secondum ASD, which we can see very well in atrial short axis slices. Then we have the premium ASD, which we can see in transaxial slices and or four chamber stack. And then less commonly, we can see the sinus, the superior sinus venosus ASD seen in transaxial slices, and the inferior sinus venosus ASD best seen in atrial short axis slices, and the unroofed coronary sinus, which is very, very rare, and we can visualize that in atrial short axis slices. Here is an example of coronary sinus ASD, where you can see the communication between the coronary sinus and the left atrium. Don't forget in the superior sinus venosus ASD to do axial sinus stack, which is the key for the visualization of the anomalous drainage of right upper pulmonary vein. Typically, what we see here, as you can see in the TO image as well, the superior vena cava overrides the interatrial defect, creating this hole between left and right right atrium. Another example of superior sinus venosus ASD. And of course, don't forget that we might have anomalous drainage of right upper pulmonary vein as an isolated lesion. So if you have a patient with unexplained dilatation of the right heart, presented with shortness of breath, don't forget to look at the pulmonary veins. It is not. It is rare, but it is something that should be in our minds. Here is an inferior sinus venosus ASD, as you can see from the atrial sinus stack. And let's move to ventricular septal defects. You can see here an example of muscular VSD. You can see it very well in sinus sequences, and also the phase contrast can show very well the jet. And there are 4 different types of ventricular septal defects. The perimembranous, which is the most common one. It is located in the membranous septum with possible extension into inlet trabecular or outlet septum. It is adjusted to tricuspid and aortic valve. There is the muscular type, which might have various locations and might be frequently multiple. Frequently, we see spontaneous closure of them. And we have the outlet, which is located beneath the semilunar valves in the conal or outlet septum, and it may be associated with progressive aortic regurgitation due to prolapse of the right aortic cusp and aneurysm of sinus of Valsalva. And then we have the inlet AV canal or AVSD type, which is usually associated with the common atrioventricular valve. It might be associated with atrioventricular septal malalignment and struggling tricuspid valve. And typically, we are seeing it in patients with Down syndrome. What do I need to know for these patients? So I need to know all the preoperative findings, and this include the type of the VSD and the position, the dilatation of the left atrium and the left ventricle, and if there is left ventricular dysfunction, the right ventricular size as well, especially in AVSD, and if there are any associated findings. For example, in perimembranous VSD, if there is a septal aneurysm, double chambered right ventricle, aortic valve prolapse, and aortic incompetence, if there is subaortic stenosis. In AVSD, we need to know if there is common, need to see the common atrioventricular valve and regurgitation. Post-operatively, we need to keep an eye and assess the residual VSD, if there is RVOT obstruction, and of course, if there is any valvular regurgitation. Very important to be precise in the assessment of LV volume and the SUNT as well, as these parameters, along with some clinical features, may guide our decision regarding close or not close according to guidelines, as you can see in this table. And here you can see on how we can see with the cardiac MRI 3 different types of VSD. The muscular VSD, as you can see here, in diastole, in systole, the jet in systole, and in short axis. The perimembranous VSD, where you can see the VSD jet in the LVOT, and then the doubly committed VSD, where you can see here the VSD jet through RVOT. So what are the red flags that I need to highlight in VSD, the assessment of VSD, if it is non-restrictive? The LV and right, the left ventricular and right ventricular size. I need to assess accurately the QP to QS ratio, and if there is any associated valvular dysfunction. Keep in mind that if the VSD is very small, CMR may not detect it, and in these cases we might consider TTE or TOE instead. Patent, another anomalous congenital disease that we can see in adults, patent ductus arteriosus. Here you can see MRA, where you can see clearly that there is a connection, a communication between the proximal descending aorta and the pulmonary artery at the ductus region. You can take phase contrast images as well and visualize better the jet. And what do I need to know? The preoperative findings, which include, of course, the PDA size, the left ventricular size and function. If there are dilated pulmonary veins, and visualize the ascending aorta enlarged PDA. Don't forget the associated findings. It can be correlated with aortic coarctation as well, so we need to have a look at that. And post-operatively with MRI, it is important to keep an eye on the presence of residual sand. So the precise calculation of the left ventricular volume, the precise calculation of QP to QS ratio, along with the associated findings, are all of them guide our decision for a closure or no closure according to guidelines. Keep in mind that you should search for PDA if you see unexplained flow artifacts in pulmonary arteries or main pulmonary artery, if you see an unexplained left atrium and left ventricular dilatation, or if you see a patient who is admitted with endocarditis with no valvular defects. And keep in mind that a large and uncorrected PDA can cause pulmonary hypertension and Eisenmenger. Then I will move to repaired tetralogy of Fallot. Patients with repaired tetralogy of Fallot represent one of the largest groups of congenital heart disease patients who are referred for cardiac magnetic resonance imaging. The AHA guidelines for management of adults with congenital heart disease recommends cardiac MRI at a frequency of every 3 years for stable repaired patients with tetralogy of Fallot who have good functional class. Common sequelae of repaired tetralogy of Fallot includes right ventricular dilatation and dysfunction, right ventricular outflow tract obstruction, and pulmonary regurgitation. Up to 20% of adults with repaired tetralogy of Fallot have left ventricular dysfunction as well. And the surgical repair of tetralogy of Fallot has evolved during the last decades from just resection of the obstructing bundles, muscular bundles. We moved to transannular paths and to insertion of right ventricular pulmonary artery conduit. So the question is, if we have a patient with repaired tetralogy of Fallot, what are the long-term complications I need to have a look at? Why cardiac MRI is needed in these patients? So in these patients, we need to have a look, to keep an eye for pulmonary and assess the severity of pulmonary regurgitation. and if there is any right ventricular outflow tract obstruction, to assess the tricuspid valve functioning, if there is residual VSD, to assess the right ventricular function and the left ventricular function, to assess if there is any aortic dilatation or any aortic valve regurgitation, and of course, don't forget to look at the peripheral, at the pulmonary artery and the branches as well for potential stenosis. These patients might also present with atrial or ventricular arrhythmias, and definitely the cardiac MRI, as we will see, can help us to find the substrate for these arrhythmias. This is the protocol that we usually use for patients with repaired tetralogy of Fallot. So it includes the CINE SSFP, the angiography for, especially if we scan for the first time in our center. We need that to assess the aorta, the main pulmonary artery, and the branches of pulmonary artery. Late gadolinium enhancement and T1 imaging is important to assess thoroughly the ventricular dysfunction. And as we will see later on, there are some specific sequences that we need to add in order to, such as coronary imaging, especially when we have plans for pre-pulmonary valve replacement. So before percutaneous intervention in pulmonary valve, take very dedicated RVOT views, and do not forget to see the RVOT only for one plane. We need more than one planes, and also we need to see short axis RVOT as well for the better assessment of RVOT function, of RVOT structure and function as well. The RV akinesia in the tetralogy of Fallot is prognostic factor for ventricular arrhythmias. So if there is akinesia, we usually measure the distance from the pulmonary valve and the length as well, and we put that in our cardiac MRI report. Don't forget to visualize the pulmonary arteries, the main pulmonary artery and both the branches for potential stenosis. And before RVOT intervention, check origins of coronary arteries, as 5% of patients of tetralogy of Fallot have anomalous origin of coronary arteries. The non-contrast navigator gated wall heart angiography is a technique that we usually use in congenital heart disease in adults, because it can evaluate the vascular structures, it can evaluate the origins and the proximal courses of the coronary arteries accurately, and we can also visualize the branches of a branch from pulmonary artery stenosis if there is any. Phase contrast, very important for the quantification of PR, of the severity of the pulmonary regurgitation. Here is a diagram where you can see the late diastolic antegrade flow in the main pulmonary artery, which is a marker, a sign of restrictive right ventricle or severe pulmonary regurgitation. And these measurements are very important when we have to decide when we will intervene in the pulmonary regurgitation, as it's not only the severity of PR, but also in asymptomatic patients, we need to assess the markers like the end-systolic volume and end-diastolic volume of right ventricle are very important for our decision about intervention or not intervention. The imaging of pulmonary artery branches is very, very important. Measure minimal diameter in 2 planes. Don't forget to take always 2 planes, because we can miss by single plane. Take the peak velocity, assess always distal pulsatility to determine severity of pulmonary stenosis, and also the differential lung perfusion from branch pulmonary artery flows is useful for unilateral branch pulmonary artery stenosis. Aortic dilatation in these patients is also common, but the acute rupture of aorta is very rare. The late gadolinium sequences are something that we are doing usually at the first scan and possibly repeat every 3 to 5 years in patients who are very stable. And what we can see is the late gadolinium enhancement in the RVOT area, which is prognostic risk factors, as this study showed, for hard endpoints, including sustained ventricular arrhythmias or ventricular fibrillation, or even sudden cardiac death. Epstein's anomaly, very important, the role of CMR in this congenital heart defect as well. It is actually an apical displacement of the septal anterior inferior leaflet of the tricuspid valve into the right ventricle and towards RVOT if it is more severe. The leaflets are often dysplastic, thickened, rolled with short cord and underdeveloped papillary muscle. The anterior leaflets are elongated and redundant with abnormal cord attachment, and there is what we call atrialization of the basal portion of the right ventricle. What do we need to take in this scan in patients with Epstein's anomalies? We need the short axis sinus tag, and we need the transaxial sinus tag, where we can see very well the Epstein anomalies. Don't forget to have a look for a PFO, possibly PFO or ASD. It is an associated abnormality which we can see in more than 50% of the cases. Don't forget to have a look for possible VSD and RVOT obstruction as well. And we can see very well all the leaflets in the Epstein's anomaly with a cardiac MRI. Typically, the definition includes apical displacement of the septal anterior inferior tricuspid valve leaf more than 8 mm per meter square or more than 20 mm. As you can see, we can see the inferior leaflet in two-chamber array RV view very well, and we can see very well the septal leaflet displacement in four-chamber view, where we can also take through plane flow, and we can visualize very well the tricuspid, the TR jet. And apart from the diagnosis, the CMR has prognostic role as well. The right ventricular ejection fraction and left ventricular ejection fraction impairment and cardiac index predicted major cardiac events in this trial. And the combination of the RV and left ventricular ejection fraction correlated specifically with 9-fold increased risk. So we have some prognostic markers in this condition, which we can take from the CMR, like the right ventricular dysplasia, the tender arterial leaflet, the massive right atrium chamber, the LV compression that we might see in these patients, the displacement of inferior leaflet. The greater the degree the atrialization is, the worse the prognosis. And if the area of the functional right ventricle is less than 1/3 of the total right ventricular area, overall the prognosis is really very poor. I will move to congenital aortic valve abnormalities and aortopathies. How we visualize them with the cardiac MRI. The imaging techniques that we use include black blood and cine sequences. Don't forget for the pulmonary artery to visualize the branches as well. We can use the 3D angiography, which is technically 3D spoiled gradient echo. We use gadolinium with this technique, but keep in mind that it is not ECG triggered. Some centers prefer the 3D wall heart, which has the advantage that it is ECG triggered, and it has a really high spatial resolution. We can take the flow measurements from the ascending aorta, of course, with the phase contrast, and as you can see here from the pulmonary artery and the branches. When we evaluate the aorta, keep in mind that we need to index our metrics to BSA, to body size. And here is a slide where you can see the normal values, the normal range of the aorta dimensions: aortic root, ascending aorta, aortic arch, and descending aorta dimensions. And how do we measure on 3D angiography? We use multiplanar reconstruction. It is double oblique technique, and the measurements should be perpendicular to vessel axis. For those who are doing CT, it's something similar with, if I can say that, something similar to CT. How we can image the aortic root? We can use either ECG-triggered sinus sequences or ECG-triggered 3D wall heart. We can measure sinus to commissure or sinus to sinus. When do we measure? There is a consensus that for the adults, we measure net diastolic diameter for children and systolic diameter. How do I measure? Echocardiograms, they suggest for echocardiogram, leading to leading edge is suggested. For CT, outer edge to outer edge is suggested. For MRI, inner edge to inner edge is suggested. The thing is that there is no consensus. What we need to keep in mind is that we should compare side by side to assure comparability during the longitudinal follow-up. Bicuspid aortic valve, it is the most frequent congenital heart disease. It affects 1.3% of the general population, and it can be associated with coarctation, Marfan, and Turner syndrome. When we assess a bicuspid aortic valve, we need always to have a look for aortopathy. The prevalence of aortic dilatation is in patients more than 60 years old is 80 to 90%. And the aortopathy, the cause of bicuspid aortic valve related aortopathy is not only genetic defect of the aortic wall, but it can also an important parameter, important factor is also the flow pattern through the bicuspid aortic valve, which can increase the shear stress on the wall and cause the aorta dilatation. So we have three types of bicuspid related aortopathy. It is the type 1 with the dilatation of tubular ascending aorta with mild to moderate aortic root dilatation. The type 2 where we have arch dilatation with involvement of the tubular ascending aorta, but the aortic root is not affected. And then we have the type 3 where we have isolated aortic root involvement with normal tubular ascending aorta and arch dimensions. And it is very important to take accurate assessment of the aorta dimensions during longitudinal follow-up, as we have different cutoff values depending the clinical scenario. Different cutoff values for Marfan, for bicuspid aortic valve, for Turner syndrome. While it is very important to follow the progress rate as well. Aortic coarctation, it affects 5 to 7% of all congenital heart disease. It is associated, can be associated with bicuspid aortic valve in 60 to 70%. You can see here very nicely the collateral flow. We can assess the diameter of the coarctation, and if there is significant, and it is significant if the reduction of diameter is more than 48% in comparison with diagram. The hemodynamic assessment is very important in order to decide the further management. So what we are doing, we take flow before the coarctation, after the coarctation. Normally we have 7% decrease of flow at diagram, but if we see more than 5% increase, that means that we have collateral flow, and this means significant coarctation. Post-surgery, we need to have a look at restenosis, which might be at 4 to 14% after coarctation repair. We need to have a look at aneurysm, which is seen up to 13% after coarctation repair. How do we deal with implants, stents, grafts? There are 3 different techniques. You can use BSSFP, but you might have high volume of artifacts. So you can use spoiled gradient echo or T1 weighted fast spin echo black blood. I think that in our center, and I prefer personally the T1 weighted fast spin echo with blood, black blood, because the artifacts are much less compared to spoiled gradient echo. This is an example of double aortic arch. I think that my colleague mentioned that as well. And I will close with the transposition of great arteries, which is characterized by atrioventricular concordance and ventricular arterial disconcordance. So that means that the aorta originates from the right ventricle and the pulmonary artery from the left ventricle. So what happens in the we correct this through two type of operations: the atrial switch, which is the old-fashioned, and the arterial switch, which is the most modern fashion. So in atrial switch, what happens is that channels are created within the atria to redirect the venous blood. As a result, the blood returning from the superior vena cava and the inferior vena cava is channeled to the mitral valve and left ventricle to get pumped to the pulmonary circulation, and the blood returning from the lungs through the pulmonary valve is channeled to the tricuspid valve and the right ventricle to get pumped to the systemic circulation. In atrial switch operation, a coexistent VSD might be open. In arterial switch, which can be seen here, what actually happens is that the aorta and the pulmonary arteries are transected above the valves and switched, so that the aorta is connected to the left ventricle and the pulmonary artery to the right ventricle. We need to have translocation of the coronary arteries, and what we usually see, as I will show you in the next case in cardiac MRI, is what we call Lecomte maneuver, where the pulmonary arteries actually straddle the aorta, and this predisposes to branch pulmonary artery stenosis. So you can see here that we have, with the orange arrow, we have a dilatation of the main pulmonary artery. You can see very well the Lecomte maneuver, which causes some stenosis in the left pulmonary artery branch, and you can see very well in the echocardiogram the flow, the turbulent flow due to this stenosis. So for the patients who had Lecomte maneuver, we need to keep an eye on the dilatation of the neo-aortic root, on neo-aortic valve regurgitation. We need to have a look if there is supravalvular pulmonary or artery aortic stenosis, and we need to keep in mind that we might have reduced coronary blood flow, which might cause or not impaired myocardial function. In atrial switch, what actually we need to assess is possible stenosis of the systemic and or pulmonary venous pathway baffles. If there is a baffle leak, if there is a systemic tricuspid valve regurgitation or a systemic right ventricular dysfunction, and of course, if there is a pulmonary hypertension. You can see here that there is a large baffle leak in the pulmonary venous baffle, causing left to right shunt, and you can see the Doppler, the color Doppler here, which was actually confirmed with the cardiac MRI. So to conclude, I will go back to the initial question: is it really necessary? So the answer is not to every good patient, but it is essential for many cases, especially when the anatomy is complex, when echocardiogram is inconclusive, and when decisions hinge on precise quantification, because the strategic use of cardiac MRI improves also the outcomes. Here I have a table, I included a table with the indications for CMR imaging in ACHD patients. It is quite detailed, but the key points actually is number one, baseline Cardiac MRI is recommended for many patients at the time of transition from pediatric to adult program. The CMR is the gold standard for the ventricular volumes, ejection fraction, flow quantification, and the assessment of extracardiac anatomy. Number 3, cardiac MRI frequency should be determined by the underlying defect and clinical status of the individual patients. Intervals between scans depend on the clinical status, on the findings that you will have on your first scan, and of course the expected rate of change. Typically we use the intervals of 3 years, but if there is a change in the clinical status, we proceed with cardiac MRI earlier. Additionally, cardiac MRI is recommended in the presence of clinical deterioration, non-diagnostic echo imaging, and definitely prior to interventional, either transcatheter or surgical. Thank you very much.
Congratulations, Eleni. Great talk, great images, great comments at the end, and they take-home messages. So, Professor Ageli, we have to move to the next, I think, because we don't have time, except in case there is a question. Cleo, do you have any question?
Well, I thought it was a really great presentation, complete, everything. Just, as a take-home message, do you think that what is the most common disease that you usually do CMR for? Is it tetralogy and maybe aortic coarctation of the aorta, or what do you think? What do you do mostly? Where do you use CMR mostly?
We usually, it is very common, the bicuspid aortic valve, and we do baseline cardiac MRI because we need to see aortopathy. And we cannot see very well the aorta, especially the aortic arch, which might be involved in bicuspid-related aortopathy. We cannot see it very well in echocardiogram. So this is quite often indication, and quite often indication, I would say, the tetralogy fellow, at least as a baseline, and then we go, as I said, every 3 years, unless there is a change in the clinical status. So this might prompt an earlier imaging.
Thank you very much. It was a great talk. Thank you so much.
Thank you.
Yeah, thank you too.
Okay.